Good day, everyone. My name is Jacqueline Nadia Sindike. I am the SLP Academe intern for December until January. So, our first topic or the topic for today is entitled So What Now? The What's and How's After Evaluation. Basically, this will be an introduction to intervention. These topics that I will be discussing today is just an introduction because I won't go into the details. This is just so it's gonna give you a jump start for your intervention class. I think that's gonna be next semester. But basically, it's gonna teach you the basics of how to proceed or what happens after the evaluation. Since this is your Diags class, you learned how to evaluate, you learned how to conduct an evaluation, prepare for an evaluation, what to do. So I'm just gonna give you an overview or insights on what's gonna happen after. So okay, I did the evaluation. What's gonna happen next? So let's continue. First, I want to talk about the post-evaluation conference funnel. So it is important that you remember that the people you are talking to, whether it be the patient's family, or whoever is involved during a conference meeting or a post-evaluation conference, this is you have to remember to be in their shoes. They are nervous. They are feeling all kinds of emotions. They don't if the patient doesn't know how he or she did, or does the family know about what you're about to say. So these are just points that you have to remember when you're discussing results with the patient's family, or other other people in the rehabilitation team. So first, flow talk. Next, you highlight positive attributes of the patient or of the client that you saw. Next is to clarify your role, to highlight communication strengths, to enlist the family in the diagnosis, and to provide written recommendations. And last but not least is to have question and answer or takeaway portion. So I'm going to go through this one by one, and I want you to try to internalize what I say because it's going to give you an idea on how to conduct a post evaluation conference. You also have to remember that what I'm going to teach you now or what I'm going to explain now is not the only way how to do it. Nobody likes a cookbook clinician. So if you have another way or another flow to do it, you can do it. You're free to do it. But this is just an overview, or this is just a suggestion, or how a typical post evaluation conference would look like. So, first is flow talk. Do not underestimate the importance of chit chat. What does that mean? Remember, I mentioned earlier that there's high anxiety during this time because the patient didn't know how he or she did, the family doesn't know what you're about to say, or basically, this is building rapport with who you're discussing the results with. So this proves as a soothing and humane transition in an otherwise stressful situation. It sets the mood or the tone for the conference, and it puts yourselves in their shoes. Empathy for a clinician is very important, and the first step pa lang of post evaluation, it really shows that you really need this trait or this value because they're already in a stressful situation. So as much as possible, as a clinician, as an SLP, you try your best to elevate the situation. Next. So the next one is highlighting positive attributes. What does this mean? Of course, you're gonna relate to them the positive the positive attributes of the patient, or of the client, of whoever you saw. So one way or another, the patient or the client is there because there's something wrong. So highlighting the positive attitudes after the flow talk, it acknowledges the general personality and intellectual strengths of the client. For example, it was a pleasure to meet Danielle. He had a delightful sense of humor. He followed directions quickly, and then he wasn't shy. He really warmed up right away. So those are like a few examples on how you can relay this message, the strengths of the patient or the client. Next, clarify your role. We do not simply treat the mouth, we look at all aspects of spoken and written language and functionality, including numerous features of speech. This is very important because as an intern during my first rotation, I after evaluation, I asked the mother na because she was watching during teletherapy, like if she had any comments, and she was like, "Teach, ngano ni ask man ka about katong mga concepts and all. Abi na ko speech pathology mo." So I really had to explain that, ma'am, that's not the only thing we do. We look at how your child interacts. We look at how he or she answers. Um, if makalabel ba, how he or she expresses. Even the rolling of the eyes, because that's already part of pragmatics. We even look at the structures because we also cover swallowing aside from speech. So it's very important that you clarify your role as a speech pathologist, especially that SLPs wear different hats and we cover different areas as well. Also, there is a fine line between managing behavior during sessions and managing behavior all throughout. We know that the OTs are um, more capable of managing behavior. So we also have to make them understand that we have our limitations as well. Okay, next. Okay, now let's talk about highlighting communication strengths. Earlier, we talked about highlighting positive attributes. Now, let's talk about communication strengths. What's the difference? So, when we highlighted positive attributes, we talked about the positive attributes of the patient during therapy. So, general. When we talk about communication strengths, it's an avenue for us to segue into talking about the the limitations of the patient or the client. So, for example, Daniel has language delay. So you can say na Daniel, during the session, modulated his voice well. He was able to articulate the sounds perfectly. He had no missing sounds. However, there was really a language delay found, blah, 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 blah. He found there was limitation with spatial concepts. So this one gives you an avenue to acknowledge also the strengths of the child within your area. So yeah, moving on, we talk about enlisting the family in the diagnosis. What does this mean? So when you enlist the family in the diagnosis, it's more of remembering what they said during case history, because right before the evaluation you had to get case history. For example, um Danielle's mom says, "You know what, Teach, si Daniel, when we're at home, when I ask him to get something inside the ref or on top of the table, he never does it. But when I ask him to do something else, he does it." So during this time, after evaluation, you say, "Ma'am, I remembered you saying that Daniel doesn't follow instructions or doesn't do what you ask him to do when you ask him to get something. It's because during the evaluation, I really saw a breakdown with spatial concepts, meaning he doesn't know which one is inside, outside, on, or in." And then that's when you get to connect the case history, pre-evaluation, and post-evaluation. So why is this important? This reaffirms the family, the mother, the daughter, the whoever, but the family who is concerned with the patient, that he or she did the right thing for opting for an evaluation. So it reaffirms them that you are there to support them, that you really found the breakdown, that you understand where they're coming from, and that you saw what they were talking about. That's okay. Let's continue. Next, Providing written recommendations. When we say providing written recommendations during post evaluation, this isn't the ITP, this isn't the IE. It's more of like a list that they can take home for the meantime, whether they opt for therapy or not. Others confuse this with, ma'am, well, I'll just follow up the IE, I'll just send it to you, email it to you. But this is more of like it can be a post-it na like sources or books or journals he or she can read for the meantime, or just something that the family or the patient can bring home. Think of it as a goodie bag that they can bring home with them after the evaluation. Next, questions and takeaway. So you also give them an avenue to express their confusion, because you have to understand that they're not in our level as well. They might have clarifications that you have to answer. If you don't know the answer, you have to be honest and say, ma'am, let me look at my resources, and I'll contact you once I know the answer. But for now, I can tell you that this, that. So if you're an intern, if you have a CS, you have to tell him or her na, ma'am, give me 2 minutes, 5 minutes. I'll just talk to my CS real quick. I just want to confirm something before I relay it to you. So that is allowed. That is valid. Um, you are accountable for what you say and what you do or what you tell the client. So as much as possible, you also have to answer their questions in a reliable way. It has to be evidence based. Also, um, this portion I do a lot. I really ask post evaluation, like, ma'am, so what did you understand? Like, what's your takeaway with everything I said, with with his results, with everything else? And then I just really am amazed and surprised because they really have insights and reflections from what you said. They really have a takeaway. So I hope you take this opportunity to sit back, relax, enjoy what they're trying to say, enjoy their insights, enjoy their reflection, listen to them, have empathy. Because building relationships during this time, since it's the first meeting, it's your evaluation, building relationships will really bring you a long way, whether they opt for therapy or not. It's gonna build your trust. It's gonna build um, camaraderie with your patients and with the patient's family, since they're also gonna help during therapy, during the journey of your client or their patient. So I hope that you do not forget also to listen to them as much as you're reporting about what happened during the evaluation. You give time for them to express also. Okay. So next, things to remember during a conference with the patient or patient's family. This is actually tips lang on how you can better your post evaluation conference with the patient, patient's family, or whoever is involved. So first is briefing. So you can opt na before you start the evaluation, you brief them on what's going to happen. So here the format of the conference is explain, critical pieces of the assessment are reviewed, critical res- uh, critical questions are reviewed. So it can be if there's a team that you review the questions that you may tackle. The interpreter is prepared to use specific vocabulary to explain the results. Of course, you really have to adjust to the language or the language of the patient's family or the patient itself. And the type of interpreting is discussed, and general procedures are briefly reviewed. Also, interaction wise, seating arrangement is appropriate. Um, I'd make sure that the patient or the patient's family is in front of me. It's gonna be hard if they're parallel to me. Participants are introduced and their roles are defined. This usually applies to when there's a rehab team present. So you say this is Doctor blah blah blah. This is the developmental pediatrician. This is the OT who evaluated as well. So at least there's collaboration and or intercollaboration. And the purpose of the conference is stated. Team's language is understandable to the parent, of course. And the therapist interprets clearly and precisely everything that is said by all conference participants. So, of course, you really have to make sure that during the interaction, um, magkasinabtanay. It's very hard if only one person understands, and especially if the patient or the patient's family doesn't understand. You don't want to um, make the patient or the parents feel, or the family members to feel na it's their fault, of course. Also, you really have to establish that you can ask questions as necessary. Like, they shouldn't be afraid to ask questions. And then, as an SLP, you have to be in charge of the situation, because if it is your conference man, because you really have to establish that you're there to relay results. Uh, the therapist interprets all the parent says. As what I said earlier, it's really important to listen. The team presents itself as a unit. The environment is comfortable, and attention is paid to nonverbal cues. That is very important for me, the nonverbal cues, because you really can see it in the face, especially as SLPs. You know when a person is confused because of the, like, for example, squinting of the eyebrows, or like looking up na because not interested. So these nonverbal cues will really bring you a long way. It's really gonna help clarify things. So for debriefing naman, this is just a reflection for you at the end of the session, or at the end, or when the doors close, na was the session productive? Was my goals really, my goals during evaluation, and my goals that I wanted to relay, or the information that I wanted to relay, was relayed well? Do you think that the patient or the patient's family understood what you were trying to say? Next, general principles of intervention. I will just be talking about an overview of intervention, because, as what I said earlier, you will have intervention next time, and I don't want to talk about the little details. This is just so you have an idea on what's going to happen, or what you're expected to do. So, first, what is intervention? So, intervention, it's a dynamic process. It's dynamic and not static. So, that's something you should remember. The clinician continuously assesses a client's progress toward established goals and modifies them as necessary. It is completely okay to have goals from the ITP that you stop midway. This is why we have progress evaluations or re-evaluations. So you check up on the progress of the clients. That's why intervention is dynamic. Also, intervention programs should be designed with careful consideration of a client's verbal and nonverbal cognitive abilities. Knowledge of a client's level of cognitive functioning is critical to making decisions about eligibility for treatment and selecting appropriate therapy objectives. In a nutshell, remember when we learned about zone of proximal development? This is very crucial, because it is very hard to give a goal that you know the patient cannot attain yet, or cannot attain in the span that is given. Next, the ultimate goal of intervention is to teach strategies for facilitating the communication process rather than teaching isolated skills or behavior. While skills are required to achieve specific outcomes in given situations, strategies enable the individual to know when and how to use their skills in new and varied learning contexts. So when you make your goals, you make sure that it's functional. You don't just target, let's say, you don't just target answering questions because it's a skill you need to learn. You target answering questions so that your patient can effectively communicate with his or her peers, right? So it's really important that you know the functionality or the strategy of why you're targeting that goal, not just because it's a skill that you need to learn. Next, your goals should be individually oriented. It should be tailored to the client. It should be tailored to his or her skills, his or her strength, primarily for the purpose of communication. So it has to be taught in a communicative context. Next, intervention should be designed to ensure that a client experiences consistent success throughout all stages of a therapy program, meaning it should be attainable. As what I said earlier, you really have to look at the zone of proximal development of the client. Next, intervention promotes a client's knowledge a step ahead. So meaning, when you target goals, you don't have to stop at where the client is. You can actually continue to make the client a step ahead for an SLP. That is already a big achievement. Next, intervention is based on scientific evidence. Of course, we really have sources and journals to where we base our interventions to. We don't just do a masako um, for the tongue just because we feel it, but more because there is evidence that it actually works. So when you do your goals or your intervention strategies, make sure that it's really backed up. You really have evidence or there's really readings about it, because you have to know also why you're doing it. Next, intervention is sensitive to a client's cultural and linguistic background. Of course, you will not target speaking in Tagalog if your patient is American, Korean. You won't target, let's say, I don't know, sentences like "I want to eat lechon" for patients that aren't that have an Islamic background. So it's really important to know the cultural background and linguistic background of the patient as well. That's why important also case history in the beginning of seeing the patient. Now let's talk about how do you make your goals SMART. If for those of you who don't know what SMART means, I will discuss it, and I hope this gives you tips on how to make goals for your clients. So S stands for specific. This is where your goals need to be very precise. It has to be specific in a way that when you read it or when your CS reads it, when your client reads it, when your client's family reads it, they know that, okay, they will be doing this during therapy. Next is measurable. Of course, your goals has to be measurable because you know that you're going to have data sheets. You're going to have criterias for when you're going to stop the goal or when you're going to move on to another goal. So, this is the only way that your goal will be postponed, will be changed, um, will be achieved. So make sure that your goals are measurable. Next is attainable. Make sure that the goal is realistic enough in all aspects that the patient can achieve the goal. Of course, when you have a 3-year-old patient, you will not be expecting him or her to do, let's say, inferencing yet, answering why questions. So you really have to make sure that the goal is achievable. It's within the age range. It's within the normal development or the typical development of the patient or the client. Also, your goal has to be relevant. It should be maybe a basic way to put this is your goals should have a reason why it is your goal. Of course, you won't be targeting OPM strengthening for a patient whose articulation is okay because OPM is intact, and you're going to use OPM strengthening as a warm up goal. I don't think that is already relevant. So you have to make sure that the reason why you're targeting that goal is because the patient needs it. You really have a rationale for it, which I will be talking about later. Lastly, your goal should be time bound. Of course, you won't put there that you'll target goals for, let's say, 3 years. Yes, you might be seeing the patient for 3 years, but your goal should be time bound. You always have to remember that per therapy session, your patient or your client is progressing. So make sure that it's based on the terms on the time frame set. Um, I usually do 1 year, 6 months, or 2 years. My most siguro is 1 year, 6 months lang. I usually do 6 months for other long-term goals. So it's really up to you. It's really up to your critical thinking. So I hope that when you make goals, you remember this. You remember to make your goals smart. Next, selection of therapy targets. What does that mean? In short, selection of long-term goals. So how do you choose your long-term goals? There's a thing called the developmental or normative strategy and a client-specific strategy. So what's the difference between the two? The developmental or normative strategy is based on known normative sequences of communication behaviors in typically achieving individuals. So this is when we apply na our UMDev or our, what do you call this, during MS cons, the timeline, like at 6 months, the patient has to be babbling, or at 6 months, dapat like this na. So this is based on when you teach your goals to the clients or to the patients, you base it on their age or where the breakdown is, and then you move your way up. Whereas the client specific strategy is it's based on the specific needs of the patient. So for me, what I usually do, I usually do the breakdown going up, but at the same time, I ask the mother or the family, like, is there anything that you want me to prioritize for now? And the mother always says, na, in school, they're talking about like this, like that. So it would be nice if you incorporate alphabet. So I really put a goal, a long-term goal that in 6 months, Danielle will recite the alphabet. So it's nice that you try to incorporate also what the parent or patient's family want to prioritize, or the patient him or herself want to prioritize as well. Next, sequencing of therapy targets. So how do we sequence our goals? So there's stimulus type, task mode, and response level. So stimulus type is the nature of input used to elicit a target response. There are three types of stimulus types. Direct physical manipulation. So this is when during face-to-face, when you have the toys in front or the books, or for geriatrics, the flashcards, memory cards. For concrete symbols, you have to choose also what are you using to stimulate their responses. It could be real objects, it could be pictures, it could be even what do you call this? Cartoonized pictures versus real pictures, black and white line drawings. Also, we have abstract symbols. So if you're giving the stimulus orally, or if you show them or you write it down, so this is the stimulus type. Also, task mode. Here, task mode. So what is task mode? It's the type of clinician support or scaffolding provided to obtain your desired responses. So this can be your cues. Remember your hierarchy of cues. So this can be either you ask the patient to imitate, you cued him, or this one's just spontaneous. Like he or she really just answered you correctly without you having to prompt. Lastly is the response level. So this is the degree of difficulty of target responses. So increased length and complexity of desired response, meaning did you ask him or her to target it in isolation, in isolation, or with a syllable, ka, or with a word, kite, and then, or a chiral phrase, I see a kite, or with a phrase itself, um, kite flying sentence, the kite is flying, or during a text. Me, I like doing talk time a lot, filling in the blanks. So I'd be like, how are you today? Um, what did you do yesterday? So the patient would respond reading the script of my talk time. Yesterday I did, and then filled in the blank, playing with my friends, blah, blah, blah. So it's nice that you get to manipulate the response levels of the patient or the client. Next is this decreased latency or the actual time between the stimulus presented and the client's response. So, of course, you have to consider, especially with the geriatric population, that it's not always going to be quick. You can't really force a patient to think about it quickly, especially if their brain has lesions. It's very hard for you to rush them because there's also such thing as mental fatigue. So you really have to vary also in your uh, latency. So you can decrease it, you can increase it, but also you have to put it during your progress notes or your session notes. Next, BCC goals. I told you about SMART goals earlier on how to make your goals smart. This BCC goals are the things that you need in your goal. These are the things that we look for, or your CSS looks for, your patients looks for. It's to make your goals smarter. Let's put it that way. So when you make your goals, you have to make sure it has these three elements. First is it has your behavior. So it has to identify specific actions that the client is expected to perform. Whether you want the client to point, to label, to identify. So this is the doing statement. Um, example of this could be, as what I said, point, label, repeat, match, name, tell, say, write, count, vocalize, ask, elevate, right? So these are behaviors that you expect during therapy. Next, condition. Condition is the portion of your BCC goal that identifies the situation in which the target behavior is to be performed. It specifies one or more of the following: when the behavior will occur, where it will be performed, or in whose presence or what materials and cues will be used to elicit the target. So usually, I think you see this in goals spontaneously, with cues, minimal cues, in all contexts. So this is the condition on what the behavior, or where or what or how the behavior has to be elicited. Next is criterion. Of course, how will you measure the goals? We go back to our SMART. It has to be measurable. So a criterion will help you do that. Um, Most used is 100% in all opportunities given, in all instances given. Better if you really have the percentage, or in 5 out of 5 trials, in 10 out of 10 instances given. So this is the part where you can measure. It's gonna help you with your progress notes. It's gonna help you know when the goal has been achieved. Will you will you what do you call this? Will you put goal achieved for a patient who only achieved 30% of the behavior with cues pagyud? No, right? So having the BCC is very important in making the goals, because this will determine whether or not you are ready to have the patient or have your client move on to the next goal. So for example, in 2 months, JK will spontaneously identify colors in 100% of the opportunities given. So here you see that in 2 months, that's when we make our goal time bound. Of course, we have to be smart as well. And then spontaneously, that is your condition, meaning no cues. It has to be spontaneous. You did not apply any prompting. Identify colors. So that is the behavior expected. He doesn't have to be labeling the cues, only just to identify them. And then in 100% of the opportunities given. That is your criterion. So once this goal is achieved, then you know that you are ready to move on to labeling, because he or she already identified the colors. Not all patients, or not all clinicians actually use 100%. There are times na you will see goals 80% and lower pa. But for me, I like putting 100% because that's when I know that this goal will be generalized. That's when I know na it's not only in therapy, he or she can do the behavior expected. Next. Oops. Next. This one. In 2 months, JK will identify colors in 100% of the opportunities given with cues. So I changed it. This one is the behavior. Sorry. This one is the behavior. This is the criterion. And this is the condition. So as you can see, I changed the condition to with cues. So it's really up to you. It's really up to the patient. That, as mentioned earlier, you really have to individualize each individualized treatment plan. That's why it's called individualized treatment plan, because it has to be for the patient good. This one. In 2 months, JK will spontaneously identify colors in 80% of the opportunities given. So same, this is the, that is the condition. This is the behavior expected, and 80% is the criterion. So as I mentioned earlier, there are really other clinicians that only require 80%, 85%, 90%. But of course, if you want to do that, you really have to find text that supports that at 80%, it's okay to move on to the next goal. So this is what I mentioned earlier, generalization. So generalization, for me, it's more of you have to know that the client does not only do it in therapy. So when you're targeting what questions, you have to know na, okay, the client can do it here at home. At at our sessions 100% at the time. Can he or she do it at home? So ask the mom, mom, when you ask JK at home, does he answer you? Does he actually like answer the correct things? Like when you ask what this is. So it's very important that you also get the the responses of your client at home, because you have to understand that you're only with the client for like an hour, and he's at home most of the time, or he's with other people. So you have to put it in contexts before you can say that your client generalized the goal you set out for him. So when you have generalization, you look at three things: the variety of stimuli, as what I said. Um, when he names objects, is it just for daily objects? Is it all objects? So is it a picture? Is it the real object itself? So you really have to see if ma-generalize niya in that aspect. Physical environment with what I said, and audience. So if it's just me, he would answer me. If it's the mom, dili siya mo answer. So it really has to be generalized in that way also. Next, when do you terminate therapy? So this is also very hard because there's really no direct or like checklist to when to terminate therapy. But these three are what's in the readings: attainment of communication skills that are commensurate with a client's chronological development, age, or pre-morbid status. So you look at if the client's age or language age or functionality is at par with his or her chronological age. Also, attainment of functional communication skills that permit a client to operate in daily environment without significant handicap. Of course, as mentioned earlier, your goals have to be functional. So once you see that the goals achieved are helping the client in his or her daily life, then that's already a sign for termination. Also, lack of discernible progress persisting beyond a predetermined time period. So, so you should see also na there's progress. It's gonna be so hard to continue on with therapy for a client who's been plateaued for a year or a year and a half. Not only is it a waste of money, but also you really have to set the boundary also as well, that hantud diri ra gyud ang patient or ang kaya sa patient, because you exhausted all efforts, you even put extra time to achieve goals, but magsigigir gas or something. So You also have to know when it's time to terminate services. So you look at treatment efficacy as well. So what is treatment efficacy? Basically, it talks about effectiveness, if your goals were effective for the client. Efficiency, if this goal helped him or her in the daily life, was it functional ba? And the effects, um, what were the effects of your goal? Did he or she do better in school? Did he or she go back to work because you already targeted this goal? He or she can speak fluently already, so he can go back to work. So you really have to look at the efficacy of the goals that you made. Also, as what I mentioned earlier, it is very important that your goals have evidence-based practice. So um, we look at three things with our journals. First is current best scientific evidence. It has to be current. You can't look at a reading 1980 pa lang when there are readings available for 2020, 2016. So make sure it's current. Next is make sure that it has clinician expertise. Make sure that the journal that talks about whatever treatment it's talking about knows what they're doing. The credentials are there. And also, don't just use journals because it has the same title, it has similar titles. Use it because it is applicable to the patient, with the patient's values, beliefs, background, cultural and linguistic factors. Don't just because, for example, when I was not younger, when I was during my mga case prep before internship, I'd get a journal just because it had the topic relating to the condition of my client. But now that I'm an intern and they require us to do these case presentations, I realize it's very important to choose EBPs because it relates to the client. I look at the age, I look at the background, I look at the primary language of the journal used. I look at the socio-emotional factors. So it's really important that when you choose EBPs, when you choose treatments for your clients, you really consider those factors because that's when you see the maximal improvement of the client. Next, rationale. So when you make your individualized treatment plans, of course, you have to rationalize why you put that goal there. So to define rationale, it is an attempt to explain or justify with logical, plausible reasons, even if these are not true or appropriate. But in our case, it has to be true or appropriate. We have to see or identify two things when we make our individualized therapy plan. We have to justify our goals with two things: needs and readiness. So, first, let's talk about the difference. Needs are why the patients need to achieve that goal, while readiness is why the patient is ready for that goal. I will show you an example to see that it is very important to justify why that goal is being targeted. It has to be a way that not only you understand it, but remember that these ITPs are being handed over to other clinicians, to physicians, to the dev peds, to the patient's family. So you really have to justify there palang on why you targeted that goal. Do not wait for the moment na the dev ped will call you na, why did you target this man na? Okay, manangyayari na. So, you really have to justify on why you targeted that goal. So here, let's see an example of an ITP. So for the long-term goal, at the end of 4 months, Ray will spontaneously code spatial concepts in all contexts. So the short-term goal for spatial concepts, the first one is, in 2 months, Ray will spontaneously identify spatial concepts regarding direction or position in 100% of the instances given. So the needs, or why this goal has to be targeted, is it will expand Ray's vocabulary and concepts, specifically in spatial concepts using direction. And then readiness is Ray exhibits inconsistency in identifying spatial concepts. So you see there that it's properly, what do you call this? It's properly justified on why you have to target that goal. Let's look at the last goal. In 2 months, Ray will spontaneously label spatial concepts regarding prepositions in 100% of the instances given. So, needs, this goal is important because this will strengthen how Ray describes certain objects according to their location, thus giving an opportunity to increase her utterances. Her readiness is Ray exhibited inconsistency in labeling spatial concepts. So there you see that it is properly justified na during conversation or during utterances, it is important to describe the location of objects because it has to be functional as well, right? Let's look at another ITP. In 1 year, Matthew will increase social emotional skills across all contexts. So let's look at the let's look at the first one. In 2 months, Matthew will spontaneously express traits of a trickster character in 100% of the opportunities given. Trickster character. Remember, we're looking at increasing social emotional skills. So one may think, like, for example, a doctor might think, why will you target expressing traits of a trickster character? How is it related to his long-term goal to increase social emotional skills? So that's why this is here in the rationale. This will help Matty increase his use of language in conversation by connecting personal experiences to the story, finding similarities between the story and others, and talking about not only what the character does, but about how they feel and what their plans, goals, and motivations for action are. So, as you can see, it was properly justified with source pa on why this goal had to be targeted. So, that's the importance of a rational. So, readiness, Mati exhibits consistency in formulating questions. So, if Mati exhibited consistency in formulating questions, he can already ask or inference on why the trickster in the story did that, processing his social emotional skills. So that is really the importance of having a precise and justified IDP on explaining your rationale well, on making sure that your short-term goals are related to your long-term goals. It would be very hard if your long-term goal would be social emotional skills across all contexts and your short-term goal would be addressing discourse, expressive language of discourse. So make sure also that there's a connection between the two, not just because expressive language. So whatever goals lang expressive language, you will put under a long-term goal that isn't even related to it. Next. That is all, guys. I hope that when you make your own ITPs, when you um when you look for EBPs, when you start talking to patients' families, to the patients themselves, you really remember this discussion because I really wish that these are things that I knew before, although I I heard about it, we discussed about it. I really didn't take it so seriously na I I embodied it. I really instilled it in my mind. So I hope that learning from my experience, you really try your best to understand what I was trying to say. If you have any questions, don't hesitate to, I think you can comment sa discussions or email me through Sir Andre your questions on how you can write better ITPs, how you can communicate better. But for now, this is what I can share to you. And I hope that you learned something from me. So, advance Merry Christmas. I hope to see you before Christmas break. And I hope to see you next year. Thank you for listening. Bye, guys. Thank you so much.